Good morning, everyone. Welcome to Friday. This is always a special day at the San Diego Shoulder Esch course where we really get a great opportunity to interact with our community therapists that have traveled, trainers, other healthcare providers that really help us do a great job as an orthopedic musculoskeletal team in order to take the full care of the patient from a full musculoskeletal standpoint. So this is a very special session, and Jim and others, and Ben Rubin, Ben Kibler, both here are some world experts in helping us understand pathology of the shoulder from a rehabilitation standpoint. So it's a huge honor to have these individuals here with us to help us understand these problems. Now, the goal of this session is to ensure that we have a very interactive group, and it's really your session. So I want to make sure, please do not be shy about raising your hand. The first talk by Don Buford and Ben DuBois, I've really asked them to make sure that this is as interactive as possible. So there's really no stupid question. The only one is the one that's not asked. I mean, it sounds cliche, but really, please ask those questions and we can make it as interactive as possible. So I'd like to start off first by introducing Dr. Don Buford. Really needs no introduction, but has really helped us understand ultrasound patient evaluation. He's devoted quite a bit of his work to this topic and helping us with really in-office and real-time feedback determination of what's going on with the patient. Don?
Thank you, Matt. Is this one turned on? Great, okay. Well, thank you, Matt, for the introduction. And again, thanks to Dr. Esch for the invitation to do some live demonstrating of ultrasound and what we do in the office. This is Dr. Ben DuBois, who's a orthopedic surgeon here in town. And Ben's going to be the narrator, and I'm going to go ahead and scan Jenny's shoulder. We're very thankful for having a model volunteer here. And what we're going to basically do is take you through the 13-point exam. And like Matt said, if there's questions, throw a hand up. We've left 5 minutes at the end on purpose for additional questions. So we'll just go through from start to finish. It should be split screen if we get this to work, where you'll be able to see the outside here, and then you'll be able to see the ultrasound image on the rest of the monitor.
Good morning. So a couple of things when you're doing a shoulder exam in your office. You want to have the patient appropriately exposed. So ideally, bilateral shoulders will be exposed. That way, if you have any reason you want to look at the contralateral shoulder, you have the ability to quickly put the probe on the other shoulder. You want to have the room dark enough to where you can get the best image quality on the screen, but you also want to have the room just bright enough so you can actually see where the probe is placed on the shoulder. A couple of things about holding the probe. The interface between the probe and the body, it's very slippery because you're going to use a lot of gel. So it's very important when you hold the probe, you keep a couple fingers free so you can keep those on the patient's body. That way your hand's kind of acting like a tripod in order to stabilize the probe on the body. So if the patient moves or if you turn away to look at the screen, the probe's not slipping and sliding everywhere, and you can keep it over the structure that you want to see. Don coined the 13-point shoulder exam, which is one way to look at the shoulder, and I'd recommend if you are going to be doing shoulder ultrasound, just do it the same way every time. That way, if you go through the same process, you won't skip steps, you won't forget to do something, and it becomes much easier to just get better and better quickly because there is a learning curve. So step one, as you'll see here in the split screen on the bottom, Don's got the probe held transverse over the anterior shoulder. So you start in the anterior shoulder, and the structures you're going to be looking at here are the biceps tendon and the subscapularis. So with the probe held transverse, the image that you're going to get here is the equivalent of an axial cut on an MRI. So it's as if you're looking down from above at the shoulder. So if you look over here on the large screen, the coracoid process will be here. This is cortical bone. So this dense white structure you see right here is the anterior humeral bone. This is the bicipital groove here, and in the bicipital groove, you're going to find the biceps tendon. So remember, on an axial cut of an MRI, it's as if you're taking that biceps tendon and cutting it and looking at it end on. So it's either going to look like a small circular structure or a small oval structure. Don, you want to show them this concept of anisotropy?
Sure. There's a couple terms that we should probably throw out there at the beginning, which is when you look at the biceps tendon here, you can see it's kind of a brighter white structure, and the term that the sonographers use and that we use as well is it's hyperechoic, hyper meaning more, and so there's more signal, it's hyperechoic. So if something is darker, it's hypoechoic. If something has no signal and is completely black, then it's anechoic. So those are the terms you may hear me throw out or hear Ben mention over the course of the demonstration. So right now the biceps tendon on its axial view here looks hyperechoic. If I change the orientation of the transducer, so if you look in the bottom left in the picture-in-picture, if I slowly change the angle of the transducer, we're just talking about 5-10 degrees, look how the biceps tendon goes away. And so this is one of the pitfalls in using this modality, is that if you don't know your sonographer, or if you're not looking at the image and at the transducer, you could be fooled, because I could take a snapshot of that and send it to Ben here by email, and Ben would say, yeah, that person's got a ruptured long head biceps because it's not in the bicipital groove. Whereas if I just rotate my hand about 10 degrees, the biceps tendon's actually there. And the reason that happens is a concept called anisotropy, where with the tendon, if you're not directly perpendicular to the structure that you're trying to image, then the signal won't be returned to the transducer and the image won't be represented accurately on the screen. So the way that you combat that is you look at things in different planes, but also once you're over a structure of interest, so say the biceps tendon, I can see it here. So if I can see it, I know it's there. But if I started out at the beginning and didn't see it, in order to really make sure that it was absent, I would want to move my hand up and down, and it's very subtle motion. Look at the screen on her shoulder. Very subtle motion, and if it pops into view, then it's really there. If I make these motions and it never pops into view, then it's probably really torn. And that's how we make the difference, okay? Or make the distinction. Okay.
So that's step one. One of the difficulties with ultrasound is if you turn the probe 90 degrees, you're getting a completely different image. It's flipping the image from, say, an axial type of view to something like a sagittal type of view or a coronal type of view. So all Don has done here, if you notice on the left side of the screen, he's now turned the probe vertically. So he's turned that probe from a horizontal direction to a vertical direction, it's a 90-degree turn. But what's happened is the image on the screen has changed from an axial type of image to a sagittal type of image. So what we have now is the equivalent of a sagittal view on an MRI. So Jenny's head would be here, her feet would be here. This is cortical bone of the anterior humerus as it's running down the arm, right here. This is the biceps tendon. So now we're looking at the biceps tendon as if we're looking at it from the side. And you can actually see those collagen bundles and fibers as it runs down the arm. This right here is probably getting close to the musculotendinous junction down here. So this is a good image to get if you were to consider doing an ultrasound-guided injection into someone's bicipital sheath. This is the typical image you would get because you're able to see the tendon, you're able to see the sheath. If someone's got a fluid collection or an effusion in the sheath, you can aim your needle tip right for that. So this is step two.
Okay, and the other thing about using ultrasound, it's one of the few, of maybe the only modality where you can really see the biceps tendon as it comes across the top of the humeral head and goes into the joint. So if someone's got some biceps tendon pathology or even a tear in that part of the shoulder, that's really hard to image on MRI scan. But here you can see, and there's other images in other positions we'll show you in a minute, but you can really see the biceps as it goes into the joint. So we'll go on to step three, which will be subscapularis.
So in this position, if you're switching to look at the subscapularis, if Jenny has her arm internally rotated and you're putting your probe transverse, you won't see the subscap because the subscap is going to be below the coracoid and the conjoint tendon. You need to externally rotate the arm to essentially deliver the subscap out from underneath that. So you can either hold the patient's elbow yourself, or if they kind of have a gist of what you're doing, you can just ask them to rotate their arm out. And as they do that,
go ahead and move slowly. Yeah.
What you'll see here is the motion of the humeral head. You'll see that ball kind of rolling in the socket, and you'll notice the bicipital groove is kind of disappearing off the side of the screen. So this would be lateral to the left. And what you're seeing here is the subscapularis, the thickness of the subscapularis attaching to the lesser tuberosity. So once again, this is an axial type of image of the shoulder. It's as if we're looking down from above. Your probe is transverse.
And then come all the way out externally.
Subscap is right here, okay? And as she externally rotates, you deliver that full insertion of the subscap into your field of view. So that's step three.
So ultrasound, the image is really based on changes in density. And as a result, differences in tissue density give us white lines or different shades of gray. And so, Ben's already showed the cortical margin here on the screen.
So this is cortex.
So there's lesser tuberosity. There's about, I don't know if it projects, but you can see in the bottom right corner on the big screen it says 2.7. That represents centimeters of depth. So from top to bottom, that whole image is only 2.7 centimeters. And so that's how we can measure thickness and measure size of tears. All of these machines have annotation and measurement packages on them. So we could freeze this picture. Go ahead and freeze that for me. Okay, great. And so then I can go on the screen here, and I could use some calipers, for example, and I could place one here, place a second one here, and that's going to give me the width of the subscapularis, which at this point, it's blocked out by the picture-in-picture, but on my screen, it's 0.56 centimeters. So if I had a question, I could look at her other side if that was normal, and it may be thicker or thinner or what have you, but I could look for side-to-side differences. There we go. Okay, go ahead.
So that's step 3. So step 4, you're still on subscap, so we're still in the front of the shoulder. Don's going to flip his probe vertically. So all he did is just a flip of the wrist, 90 degrees. Once again, you're turning here from an axial type of image to a sagittal type of image. So now it's as if we're looking at her shoulder from the side. And what you're going to see is subscap, the thickness of the subscap, kind of the upper part of it, the mid portion of it, and the lower part of it. So we're basically right over lesser tuberosity as if we're looking from the side.
And this is a great way to see those superior third subscap tears that we all see arthroscopically as well. You can make that diagnosis using ultrasound in the office in just a few minutes.
So step 5, we're still one more in the front of the shoulder. So turning the probe again, transverse, we're sliding over to see the coracoid process and where the subscap will disappear below the coracoid and the conjoined tendon. This is a good image to get and check dynamic images. And oftentimes when I'm doing an exam in the office, this view right here, if someone's got a full thickness rotator cuff tear, you'll see a fluid collection just superficial to the subscap. As soon as I see that, I usually am going to see a supraspinatus tear. Okay, so if you see a big fluid collection there, which Jenny doesn't have, right about here you'll see a big pool of joint fluid kind of pooled up there, and that's usually extravasation of joint fluid that collects there. So if you see that, you're probably about to see a supraspinatus tear when you look at it.
The I can show on this. The coracohumeral interval, if we wanted to measure, I know it's basically published as a CT measurement, but we could set that on the anterior humeral cortex there, and we could measure the undersurface to the undersurface of the coracoid, and that's about 1 centimeter in her. The measurement's hidden by the picture-in-picture, but on the screen here it says it's 1.08 centimeters. So we could measure that distance, and you know, if you believe in subcoracoid impingement, this is a nice way in the office to diagnose it and to quantify it.
So this dense whiteness right here, that's the cortex, the anterior coracoid. So Don, you want to show that one more time?
Let me go back and show you. Yep.
So coracoid process right here. That's the tip of the coracoid right over
that bright white line there.
Subscap kind of running below it, deep to it, okay?
Okay.
So
that's all 5.
Now we're moving on. Next step. We've finished in the front of the shoulder. We're going to move on to the supraspinatus. So normally in an ultrasound exam, this is where you're going to find most of the pathology. So what we've done is you've noticed Jenny's repositioned her arm. So she's got her hand on her hip and she's brought her elbow back.
Some of the other protocols for shoulder ultrasound will show a different position. Go ahead and show the other. With the patient's hand, with the hand pointing down and really farther back on your butt, basically. And what I found when I started using this was that patients with sore shoulders or post-surgical patients, this hurt. Okay, it hurts me and my shoulder is okay. So we changed it, and we just have the patients get their hand back as far as they can and bring their elbow in as close to their body as they can. So that was one of the subtle little changes we made in our protocol. And it still gives us the same good pictures, I think. So we'll go ahead and start at 0.6.
So the goal of doing this real quick is you're attempting to deliver the insertion of the supraspinatus out from underneath the acromion. If you just hold your arm kind of like this and you try to see the whole supraspinatus, you're not going to be able to see that because ultrasound waves are not going to go through bone. They're not going to go right through the acromion. So what we're trying to do is we're trying to deliver the insertion of the supraspinatus out from underneath so you can see it. So what we've got here is the probe held basically parallel with the fibers of the supraspinatus, and the goal is to get a coronal type of view. So this is usually the money shot here, similar to what you see on an MRI. We're looking at the anterior supraspinatus. So left side of the screen would be lateral, right side of the screen is medial, and it's as if we're looking at her shoulder from the front. And as we do that, we see cortical bone. This dense white line you see right here is cortical bone, okay? This is the supraspinatus here. And this supraspinatus she has looks totally fine. A nice thickness of the supraspinatus as it inserts on the greater tuberosity and the anatomic footprint right here.
Now, a couple things. You can see on the edges of the image here, it looks kind of fuzzy, and that's not a problem with the machine or with the modality. It's just that Jenny here is so petite that our transducer is not completely on her shoulder. And as a result, I'm able to image, so here's the lateral aspect of the insertion. I can see that very clearly. If I want to go back medially, I have to rock the transducer. If you look at the bottom left, I have to rock the transducer back, and that shows me medially going back into the supraspinatus muscle. And that's just a function of having a smaller patient. You know, some of our big, nose tackles, the whole transducer fits nicely on the shoulder, and you don't have to worry about that. But it's just another little tip. And if you're going to be in the seminars in the afternoon or later on this morning, you'll see that as well. But she's got great anatomy. It's very easy to see the difference between her deltoid and her superior border of her supraspinatus. Talk about the ammo belt, the cross in the front, how we're paralleling those lines.
Yeah, so basically what you're trying to do here is the way I think of it is, if you've got her hand here and back like that, you're trying to keep your probe essentially parallel to the fibers of the supraspinatus to give yourself that perfect coronal image. So if you can see, I don't know if you can see it on the screen, but her supraspinatus is originating up here, the muscle belly. As it's coming forward and anterior, you'll notice Dawn is essentially parallel to that. That's going to give you your best image of coronal. If you want to see a sagittal, you're going to turn your probe 90 degrees, okay? The next step here, after you've satisfied yourself with the anterior supraspinatus, is to go to the posterior supraspinatus. And typically this isn't a situation where you have the probe in the anterior supraspinatus and you simply pick it up and move it and place it again. This is more like scrolling front to back, because you really want to see that supraspinatus insertion anterior to posterior. So what Don's going to do here is, starting in the front with the probe, he's just going to kind of start scrolling backwards. And as he does this, you're going to go through the mid part of the supraspinatus insertion, and you're going to start to get into the posterior insertion.
You can see how the footprint changes as well. In the anterior portion, just behind the rotator interval. So if I go way anterior, guess what that is? There's biceps tendon coming through the rotator interval right there. So just behind that, it's going to be the first part of the supraspinatus where a lot of those the tears happen. So we always look here first. And then as we scroll back, look how that cortical margin, the footprint changes. It kind of rounds out as you get back towards 0.7. This is all still supraspinatus. So
one kind of tip there, if you ever get lost, which it really is easy to do when you're first starting out, if you can find the biceps tendon, that'll help reorient yourself where you are. Because if you're looking at a coronal type of view and you see biceps in the cuff interval, you know you're just anterior to where most tears are going to occur, the supraspinatus. So oftentimes I'll go directly to the biceps in the interval, and I'll just come back 1 centimeter. I'll just scroll back just a little bit, and that's showing me typically where most tears are going to occur. So that's a good place to start.
So let's do a dynamic test.
So in this position, this is a good opportunity you have to do something called a dynamic contraction test. And the goal of this test is to uncover potentially non-displaced full thickness tears or significant partial thickness tears. Because in the static image, sometimes you don't appreciate that there's a full thickness or a high-grade partial tear, especially if the tendon hasn't retracted at all. So what Don's done here, you won't see it on the screen up here, but down here in real life, what he's done is he's got his hand kind of blocking Jenny's elbow. And Jenny's doing an isometric contraction against his resistance, okay? And as she's doing that, she's contracting some muscles, one of which is the supraspinatus. So normally, in an intact rotator cuff that has no tear, you're really actually not going to see very much here. This tendon is not going to move at all, essentially, because it's very adherent to the bone. It's not just pulling away from the bone, so you're not going to see very much. In people who have a full thickness tear or a significant partial tear, you'll actually see some retraction of these fibers medial. Okay, now she doesn't have that, but I've got in the labs later on, I've got a very good video of a full thickness non-displaced tear that was diagnosed by this exact maneuver, the dynamic contraction test.
Okay, you want to go to...
So moving on. So now we're done with the coronal view. We're still on supraspinatus, but we're going sagittal view. So all Don has done here is he's flipped his probe 90 degrees. Now it's as if we're looking at her shoulder from the side. It's a sagittal view, and we're anterior.
So
and
I
once
want to find
again,
the biceps. There's that circle, the biceps there.
So right here what we've got, this is cuff interval here. So biceps is here. Upper part of the subscap would be here. Anterior supraspinatus is this structure right here. So this is cortical bone of the humeral head. And you're really seeing supraspinatus, anterior, middle, posterior, starting to get into infraspinatus back there.
And now, in somebody as thin as Jenny here, you can see the articular cartilage. It's that hypoechoic, or that black line just above the cortical line. So that's not pathologic. That's actually articular cartilage. You'll lose that in some larger patients, but in somebody who's thin, you'll see it. In somebody who has a full thickness tear, it kind of uncovers it, and you'll see it well also. So it's a tip-off towards cuff pathology in somebody who's not thin, if you can see that well. Okay.
Moving on to the next step. So what Don once again is doing here is he's just scrolling anterior to posterior. Yeah, we've got a question here. Go ahead.
Well, what would a tear look like in this view right here where we see the supraspinatus tendon?
Typically tears look dark. So there's a void in the tendon. You may see fluid. Fluid shows up as being black on the screen. Okay, so tendon is kind of this intermediate white signal. Fluid is black. So typically these types of tears, particularly if it's a full thickness tear, there will be a fluid-filled gap there. And I've got a million of them in the labs later today to show people. So that's typically what you would see here. And you may see a surrounding fluid collection outside of the rotator cuff in the subdeltoid or subacromial space.
There's a couple other things on the sagittal view that we use. Go ahead and unfreeze. What you notice here in a normal tendon, those two white lines that represent the inferior and superior border of the supraspinatus are basically parallel. If somebody's got a torn cuff, then those lines tend to converge wherever the tear is because there's no tissue there. And what happens is the deltoid muscle up above tends to drop into any defect in the cuff. And so we'll look for areas where there's not symmetry. So right now, the width of that tendon looks pretty symmetric, but in a tear, let me come up a little bit more anterior. In a tear, which a lot of times we'll start anterior here, just behind the rotator interval, you'll see an area where those two white lines, show the two white lines I'm talking about, the top of the humeral head and basically the top of the supraspinatus, those two lines will get very close together and there'll be a large black spot, for lack of a more medical technical term. So we're looking for areas that are dark in the tendon. Dark is usually pathologic, Okay. So let's go, so we've done 8 and 9.
Yep, so now we're going posterior. So he's scrolled this, once again, he's scrolling his hand back, he's going posterior. You're still in that sagittal view, and we're getting back into the posterior supraspinatus and the upper part of the infraspinatus back here.
Okay.
Once you're satisfied with this, you're kind of done on the side of the shoulder, and you're moving on to the posterior shoulder.
Okay, let's do posterior.
Okay? So you're going to reposition the arm here, so that the patient's going to now put their arm kind of back in their lap, essentially, and rest it here. Don is holding the probe transverse once again, so we are getting the equivalent of an axial view, as if we're looking down from above. So this is a good way to look at the posterior infraspinatus insertion.
A little more gel.
So what we'll see here is you'll see the ball, you'll see the joint, you'll see the glenoid, and you'll see the insertion of the infraspinatus posteriorly. We're just changing the depth here because I think that picture-in-picture is kind of in the way. So
yeah, go deeper.
Here we go.
Okay.
So what we've got here, once again, it's as if we're looking down from above. This would be posterior. So you've got skin, you got posterior deltoid. This right here, this thickness between that white line and this white line, this is the infraspinatus, okay? The muscle belly's over here medially. This is muscle belly of infraspinatus. It's coming over here, it's turning into a tendon. The tendon is inserting over here laterally on the posterior tuberosity. This down here is the joint, okay? So there's another step to look specifically at the joint, but this is just to give you an idea of what that dense white line, that's posterior glenoid there. So a couple things to notice here. As you're moving passively or actively the arm, so Jenny, why don't you just slowly internally and externally rotate your arm. What you're going to see here is this excursion of the infraspinatus, and as she internally rotates, if it's attached like it should be, you'll see the tendon basically coming along for a ride. People who have, say, cuff arthropathy or they've got a massive rotator cuff tear, you're basically going to see deltoid touching bone, and you're not really going to see much as far as the infraspinatus here. It'll either be very, very thin, or there may be a fluid collection here, so you're not going to be seeing this nice, thick, healthy infraspinatus.
And again, in somebody as thin as Janie, and she's going to think I'm angling for a Christmas card or something, but her anatomy is really good to demonstrate because you can see the central tendon in the infraspinatus, and you can see the muscle fibers coming into that tendon, okay? And that's just great anatomy that you can't really appreciate any other way. As far as the dynamic part of this, whatever is not, you can see the humeral head moving. Let me get centered over the joint. There we go. So you can see the humeral head moving. You can see a kind of a bright white triangular structure just to the right of the humeral head. That's labrum. So this is the image that we use when we're going to do posterior injections into the joint. And the needle would come from high on the left side of the screen, and we'd angle or aim for the labrum, and we'd enter the joint right there. Basically the same, or maybe a slightly lateral to a typical posterior arthroscopic portal. Okay, but we could watch the needle go right into the joint for whatever type of injection we're trying to do, whether it's for a DJD or adhesive capsulitis or even for gadolinium for an arthrogram.
Okay, moving on to the next step. So Don's going to flip his probe vertically here, and what you're doing, once again, is with that flip of the wrist, you're turning this from an axial type of view to a sagittal type of view. So now we're getting a sagittal side view of the infraspinatus.
Yes, perfect.
So the dense white line, once again, that's cortical bone, infraspinatus tendon, kind of top to bottom is here. This is a bit of a peculiar view, and honestly, sometimes we just skip this view unless we think that there's something going on with the infraspinatus. But this is part of the 13-point exam.
Back to...
Next step here is really focusing in on the joint. So he's gone medial here. So what he's done is he's slid medial from where the insertion of the infraspinatus is to really focus over the joint here. And so once again, posterior glenoid is down here, okay? Labrum is here. Humeral head is here, so the joint is here. Now people who have, let's say someone comes in and they've got DJD of their shoulder, if you're going to do an intra-articular injection for DJD, oftentimes people will have an effusion, they'll have fluid, okay, and it'll be dark here, they'll be ballooned out, this darkness, that's the fluid, the joint effusion, and that makes it very, very simple to aim and put the tip of your needle right into that if you're going to do an injection, okay?
Okay.
So the last step is looking at the AC joint. Once again, this is a step. If someone comes in, they've got absolutely no pain over their superior shoulder. I may not even look at their AC joint on ultrasound, but if someone does, what Don here has is the probe parallel to the clavicle, parallel basically the front of the shoulder here, and what we've got is a very superficial view. This is only essentially millimeters below the skin. We've got distal clavicle here, acromion here. The joint itself is right here, and you can actually even see the capsule of the AC joint superficially here.
If I was showing you.
This is a tough one to get, by the way, sometimes, because people are so thin and it's so superficial. Here's the distal clavicle, here's the acromion, and the capsule is this sort of white line right here, and there's just a little bit of fluid inside the joint. So that's the AC joint. So if you were to do a ultrasound guided injection of someone's AC joint, this is the view that you would get, and you can just slip your needle right underneath the probe, and you would just view it kind of just coming in lateral to medial until you pierce the capsule, stick it right in there and inject. You can actually see the fluid going in to the AC joint.
So that's the 13-point exam, and we've got about 4.5 minutes. Are there any questions? Yes?
What depth of penetration can you get? Practice in Nebraska, considerably larger or more fluffy?
Absolutely. Yeah, I'm in Dallas, so we get some of that too. You can actually go ahead and dial it down. This is at 2.7. Really, the short answer is we have about 6 centimeters to 7 centimeters to play with to get maximal resolution. There's frequency trade-offs, and make a long story short, the higher the frequency, the less depth you get into the body. So trauma surgeons that are looking at abdomens are using like 7 megahertz frequencies, whereas we're using 13, 14 megahertz to get good resolution around the shoulder. So this is at 6 centimeters, for example. It's going to be off the screen, but you can get down 6 centimeters and still get pretty good resolution. Beyond that, it gets a little bit tough.
Now they do make other probes. They make a curvilinear lower frequency probe, which in orthopedic applications is really good for, say, if you're going to do an intra-articular hip injection. So if you do a lot of hips and you're going to be doing that, that's probably worth purchasing that probe because they are pricey. But if for the shoulder or more superficial structures, a probe like this is all you're going to need.
What's the max this will dial down to? Do you know? Will it go down to?
Any other questions?
This will max out at 6. Okay.
Yeah, go ahead.
That's a simple question. With all that ultrasound gel all over the place, how do you just get prep for injection? How do you work with gel?
Great question. Basically, if you ask me, here's my probe, my gel's right underneath my probe. My needle's entering the body from a different location that's remote from where my gel is. For example, if I'm doing a subacromial or let's say I'm doing a glenohumeral injection, my probe is actually more lateral, and I've angled it back medial to see the joint. My needle is coming in from a more medial direction, so the two are just separated by several centimeters. So you just be careful, essentially. You just prep out in one spot, you hold your probe in the other spot. But it can be challenging when you're first starting out. So if you're starting out to do it, you may want to have your assistant holding the probe and holding it for you with the view that you need on the screen, and that way you can fully concentrate on keeping your area sterile.
The other thing is they make these little silver sterile packets of gel, and they're about $1 each, so it's well worth spending the $1 to get the sterile gel, and it just comes in a little single-use packet that's double wrapped, just like things in surgery. And you can just use that sterile gel, and that way you can scan right through it, you can inject right through it because it's sterile.
Someone asked about a slap, I think. Was that you? As far as diagnosis of a slap lesion? No, ultrasound is basically still, no. You really can't see that type of intra-articular pathology. So in cases like that, if you've got a concern over an intra-articular issue, you probably still want to go for the MR arthrogram. But neither Don and I hang our hat on an ultrasound as far as diagnosing some type of labral pathology.
Yeah, the problem is the ultrasound signal won't go through bone. So as soon as you hit a bony structure, you're not going to get any diagnostic imaging below that, which is why when you see the cortical bone on supraspinatus images, there's no resolution to the bone marrow or anything else. So anything intra-articular, this is not the way to go. Although you can see that posterior sliver of labrum to do an injection, you can't really make a diagnosis of a labral tear or a Bankart, anterior or posterior. It's really the best for rotator cuff stuff, biceps tendon, rotator cuff, yes.
How good is it to see fatty degeneration in the muscle?
That's a good question that we get all the time, and we're working on trying to quantify it and trying to have a system where you can say at a specific spot that there's a measurement that would be reproducible. And to my knowledge, that hadn't been done yet, because I know that I'm one of the guys working on it. But you can't really see, let me just give you an example. Can you go back to the ultrasound image? You can see the muscle belly. This is her infraspinatus. Can you guys switch back to the feed from the machine? Great. So this is her infraspinatus, which I think arguably for me is the most important muscle to determine if there's atrophy when I'm trying to sort out if I can repair something arthroscopically. So here you can see she's got robust muscle, but in terms of quantifying it, it's difficult. I've tried, it's really difficult. I've tried with an MR arthrogram on the screen also. And so I don't really use it. If I really have somebody where I need to make that decision preoperatively, I'm still going to get an MR to see that and get that information. Jim?
If you see a cuff tear and the patient decides to have surgery based on your conversation, how often do you do an MRI on that patient? Like 100%?
No, that's a good question too. That's a question my partners asked when I started doing ultrasound. Yeah, one of the ways to think about it is the older the patient is, the more likely the status of the cuff is to be the only clinical question that we're trying to answer. So if you have a Medicare age patient, we don't care if they have a degenerative type 2 slap, we don't care if they have some labral fraying. We really want to know is the cuff torn or not in order to guide their clinical, in order to counsel them, okay? So the older the patient is, the more likely I am to use this as the only diagnostic modality. If I see a full thickness cuff tear on this and the patient's 62, they've been symptomatic for 9 months and they want something done, I'm not going to get an MR. So it approaches 100% where I don't get an MR, Medicare age or older. Somebody who's 30 to 50 or something like that, active, and they have a partial cuff and it may not explain all their symptoms, or I'm still worried about the status of their intra-articular anatomy, then I'll get an MR arthrogram. But a lot of times in those patients, we'll still get ultrasound at the beginning because we haven't done any kind of conservative care, no physical therapy, and I'd like to know if they have a full thickness cuff tear before I send them away for 6 weeks of physical therapy, because I don't want to miss somebody who had a full thickness tear, when I can make that diagnosis in 2 minutes in the office.
I think we're out of time. We're zeroed out here.